on developing and improving the SQUIRE reporting guidelines for writing and publishing quality improvement work.
Thank you, Carolyn, for the introduction. Thank you for joining us. It's actually great to be here, an opportunity to share our work. We're going to tell a little bit of a story, so we do have sort of this 12 years of experience with the Squier guidelines, and would like to show you sort of where they began and what the need was, and then sort of where they are currently and where they're going. Just want to acknowledge both the Health Foundation and the Robert Wood Johnson Foundation who funded the work. So we had this dual funding from the UK and the US that was really quite nice. And then Louise, Hilary, and I are all employees of the Department of Veterans Affairs in the US. So that's actually that middle thing. So we work for the VA system, and they've also been incredibly supportive of this work, as has the IHI and the medical school at Dartmouth, and also the medical school at the University of Iowa. So these are the objectives for the, we have about 45 or 50 minutes of prepared material, and be able to take questions. I want to talk about our journey of creating Squier 2.0, and then really want to focus on these three key components that distinguish Squier 2.0 from its predecessor, about rationale, how you describe context, and then the study of the intervention. These are actually some pictures from our writing conferences. So we've done writing conferences in the US and in New Hampshire. And the one on the right side was just from this week up in Leicester. And we did a writing conference, had about 30 attendees of folks coming to write and work on their improvement work. So we'll start with a story, and this is how many of you here are clinicians? Okay, so at least one. So this is actually a really popular article. This is a article from 2006, and the date matters here because I'm going to follow this along as we go on. And it's an intervention to decrease catheter-related bloodstream infections in the ICU. So this goes by some different name. This is sometimes called the Michigan study, sometimes called the Keystone study. It occurred in the state of Michigan in the US. And Peter Pronovost, who is the lead author here, he was not in Michigan. He's actually in Baltimore, but they did the work with the Keystone Group in Michigan. What's interesting about this is that the intervention here was not, a fancy antibiotic impregnated catheter or anything like that. The intervention here was a checklist, and it was a checklist of 5 honestly rather simple things to do, but putting them together to decrease infections. And it was wash your hands before you start the procedure, wear full barrier protection to protect the patient from the bacteria on you. Don't use the femoral site. So these are large bore intravenous catheters that usually go either in the neck, the top of the chest, or can be in the groin. So one of the parts of the checklist is don't use the groin if you don't have to. The third one was to monitor it and take it out. Or the fourth one is to monitor and take it out as soon as it's not needed. And the skin cleanser, they recommend a certain type of skin cleanser called chlorhexidine. So that was a checklist. And this is actually an incredibly well done project. It was over 100 intensive care units in the state of Michigan. The results are exciting and incredibly helpful. So let me walk through the result table with you because I think it's really helpful. It's a little busy, and I'm going to try to use the pen on here to see. Let's see how this works. We'll see if it works. Over here is the so that column is sort of the time frame. The work rolled out over 18 months. So you can see, so down there is the end of the timeline. And then here's, this is the number of ICUs. It was 55 that started. And this number is actually important because that's the baseline rate of infection. So 2.7, that's actually the median number of infections per 1,000 patient days. So that's how they did that. Now, if you follow down that column, what you see, it goes to 1.6, and then you see a lot of zeros. That's spectacular. Essentially, the median infection rate is going to 0. Now, in the parentheses, there's some rate that's still there. So the infections weren't totally gone in all the intensive care units, but the median went to 0. And when you look at the other column, so there's columns here about teaching hospitals or non-teaching hospitals. Now I'm using this too much. Okay. And also the number of beds, sort of smaller hospitals, larger hospitals. No matter how you look at it, they all, that bottom line, that 18-month line, they all got to a median of 0. Great results. But if you're at an intensive care unit in Oxford or in a different part of the US or in Australia, you're sort of left with these questions when you read the article. You're sort of like, well, what actually happened? How can I get these results in my ICU? And then, like, can I even get these results in my ICU? What's interesting about this article, the article's from 2006, they're follow-up articles. So 2008, article by Charles Bosk and Mary Dixon Woods and Peter Pronovost in The Lancet. Now, this was not a highlighted article. This was a viewpoint, kind of off to the side a little bit. Great journal, but not a major article. And it was reality check for checklists. And look what they say. They say the Keystone study was oversimplified. The reasons that checklists have not penetrated medicine are cultural and social. And a technical solution, a checklist, is being used to solve an adaptive, a sociocultural problem. So when I present this to my medical students, and I talk about this, or with resident physicians, so physicians in training, they sort of look at me and they say, I went to medicine for science. I didn't go into medicine to solve social problems or cultural problems. That's not what I came into this for. Little do they know what they're getting into. But this is what they found in looking back at this work by Pronovost. And they say that even the word checklist obscures the complex labor necessary to create the local faith in the checklist. I love this list of these 5 things at the bottom. They say, we didn't even highlight these in our article, but they were really important. I look at like leadership, safety improvement, training, safety and improvement training, sound measurement, feedback from all frontline staff and professionals. This is my favorite. There were more than 100 Keystone checklists because everybody adapted it. So if you take this and you submit your article to the New England Journal or to the Lancet or BMJ, and you say, well, we did this work and there wasn't one checklist, we had 100 different checklists and everybody changed it, but don't worry, the results are sound and everything, it won't be looked on as favorably. But this is sort of the reality of what happened. And from someone who wants to take the data and make it useful in my ICU, this ends up being a little more important than just saying checklists work or they don't work. The story continues. So this is in 2011. So this is now 3 years after, this is 5 years after the first article, 8 years after the work. The work started in 2003. And look at the title, Explaining Michigan, 8 years after the initial work for a checklist. They're still trying to explain what happened. But it's fascinating. And again, Mary Dixon Woods, Charles Bosk, and Peter Pronovost is also a co-author on all these. And they say QI studies are remarkably poor at describing exactly what a program comprises. And they say these 6 things now. Michigan achieved widespread success by, and look at the words they use here, I think are so interesting. So generating pressure to join, a densely networked community. This is it's reframed as a social problem. We shaped a culture of commitment. These last 2, harness data as a disciplinary force. And hard edges, checklist itself, activist tactics, and the data. The words they use here, what they find, this wasn't just about getting a piece of paper and handing it off to some ICU and saying, okay, here, go ahead and do it. This was really hard. The words here, I think, sort of give a flavor of how difficult it was to make the checklist work at the local sites. But it's just something you don't get in the original article. And thinking back to 2006, you actually wouldn't expect it in the original article. This as a sort of an introductory story, I think, is the backdrop to which the Squier guidelines were developed then. And the Squier guidelines, Squier 1.0, came out in 2008. So these are the standards for quality improvement reporting excellence. It's a framework to help you write up your quality improvement work. So the question is, why do we need Squier? When you think of improvement work and service improvement and audit and feedback, it's often done by busy frontline professionals who are more concerned with making things better than generalizable truths. They often don't have incentives or training in publishing. And the reality is, even still today, editors, peer reviewers are unfamiliar. And writing about improvement is hard because it's not that straightforward drug A versus drug B or thing. It's more complex. It's about context dependence and iterative nature of the work. Improvement work by nature changes. Those checklists change because they have to, because the general checklist doesn't work in my setting. So you figure out how to make it work. And Squier is intended to help you report that so others can learn from it. So 2012, we began working on transitioning from Squier 1.0 to Squier 2.0. Lots of reasons for this. The nature of improvement work was changing. There was more information about and guidance about studying context, new methods about doing improvement. And we had 3 steps to this. The first was to evaluate the initial guidelines. We looked at usability and clarity. This was a qualitative work with semi-structured interviews. And Louise led that work, and that actually is summarized in a nice article in BMJ Quality and Safety. Our second step was to do revisions. And so we had a kind of a panel of experts, had about 30 to 35 experts who met twice in 2013 and 2014. And that eventually led to pilot testing, which is something that we're not aware of others have done with guidelines, of actually taking a draft version of guidelines, sending it out. We sent it out to about 70, we recruited about 70 individuals. 44 of them sent back a draft and a review of using the guidelines and saying, well, guideline number 5, this is where I think I put it in the paper. And we evaluated all that. We used that to create our next versions. We shared it with 11 journal editors and got some feedback from them. And then what we call version 1.8 was sent to 450 individuals around the world who we consider friends of Squier. It's basically our email list that we have. And then we also posted it for public comment. This work also is available. So if you're interested in this, if you search for Louise Davies 2015 BMJ Quality and Safety, you'll be able to find those articles if you want to know more details. This is what Squier looks like. Like most things currently, it lives on a website. So it's squier-statement.org. And this is just the top of it, but you can see the items. So there's some instructions for authors. And then you can see title and abstract and problem description. So there are 19 items total. I'm not going to walk through all of those. This is just to give you a flavor of them. And there also is a glossary. So things like the word initiative or problem. What we found in our evaluation of Squier 1.0 is that some individuals were quite confused by the terms we used. So we defined them. Now, they're not necessarily the dictionary definitions, but they're the words. We want to be clear about how we use these. Even words like system, which in the improvement world you would think everybody knows what a system is, right? It's part of what you do in quality improvement. But there was quite a difference of opinion on that. So that's our website. I'm going to come back to that in a minute. There are 4 major improvements. The first was terminology and language. We clarified the language. Interestingly enough, in the guidelines themselves, we don't use the word improvement. The feedback we got, people said, well, that means I can only publish things that work well. And we said, no, we actually don't want that. We want to know things that don't work well. We want to know what you learn. What we really want to publish is the learning that happens. So we were very careful about the language. I'm sure there's more work we could do on it, but we worked on it. And there are things that these 3 components that we call either the 3 pillars or the 3 birds. We call them the 3 birds because we like this picture. But they really kind of are the pillars about writing about improvement and doing improvement. The first is theory and rationale, and the opportunity to really describe why the approach was chosen and why you thought it might work. The second is context, where the work was done and what's important about the setting. In research, you're often trying to control for the context, and you do that through your design and also in your analysis, where you're trying to deliver context-free information. Improvement work is sort of just the opposite. You're trying to describe and understand the context and its impact on your intervention. And then the last one is the study of the interventions. So you're really reflecting on the work that was done. Did things get better for the reasons you thought? So those are sort of the three main components. We're going to walk through these. I'm going to go through theory and rationale first, and then I'll hand off to my colleagues. Rationale. So back to the website. The website has this tool I think is really quite helpful, which is called the E&E document. It's explanation and elaboration. It provides examples for each of the items. So this is the item for a rationale, which is about, you can read that there, number 5. It's informal and formal frameworks, models, concepts, and/or theories used to explain the problem, the assumptions that were used to develop the intervention, and reasons why the intervention was expected to work. Okay, fine. So that's the item. Not entirely understandable just on its own. But then you get two examples, example 1, example 2. These are from literature, from published literature from 2015 and earlier. If you go down to the explanation area, there's sort of commentary on these examples. You get things like, well, a rationale is always present in researchers. However, it's important to make this explicit and communicate it in healthcare improvement work. Or this one, you say the authors use an integrative theoretical framework for the intervention development. So the examples and explanations and this is for all 19 items, begin to show you places where it was done not perfectly, but done pretty well in the literature, and then offers the commentary on it. For a little bit more commentary on theory and how it fits with improvement work. This is really a spectacular paper from BMJ Quality and Safety from Frank Davidoff and colleagues from 2015 about demystifying theory. Those of you who are researchers, you sort of know you always are using theory. In improvement work, we don't, but it could really help. And the reason is this, is that personal intuition is biased. Formal theory enables maximum exploitation of the learning and accumulation of knowledge, and promotes the transfer of learning from one project, one context, one challenge to the next. So when you think about theory and rationale, I'm using theory and rationale interchangeably here. But when you think about that, it fits with the publishing of this work, because you're really trying to share your work. You're trying to push it out, and you're trying to have others understand. It's intended to increase the learning. This doesn't really happen in QI. Theory is actually really difficult. It's the whole reason we chose the word rationale, because we actually found from talking to the end users, they found theory difficult, even sort of intimidating by folks. So we chose a different word. I'm still not sure I like the word we chose, but it's what we chose. So it's there until we do Squier 3.0. And what does it look like? There's actually a whole bunch of different kinds of theory, and the paper does this nicely, where it goes through in depth about different causal and explanatory, mid-range program theories, and on and on. But the paper also is very simple. The paper has this depth, this paper, and it also is very practical. So if you're interested in theory, I invite you to look at this. I like this quote from Mary Dixon Woods, and I usually hear it from Louise. I've never heard it from. I've never heard Mary say it. But it says that you're answering the question: why do you think this intervention or these interventions will work in this setting at this point in time? So you're really getting to that component. So let me give you two examples here just to show you. This is an example of a paper from BMJ Quality and Safety. The title's over there on the left-hand side, Developing and Evaluating the Success of a Family-Activated Medical Emergency Team. So this is not the code team. This is a team that's often called in hospital when a patient is starting to not do well, and the team is activated by a doctor or a nurse or a respiratory therapist or a medical person. What they wanted to do was to allow the family to call this team. So it's not the primary team, you're actually activating a different team. This was actually a big deal. And look what they wrote here. I thought this is a good example of their rationale for doing this. So families have a unique knowledge of their child's normal behavior and temperament and may recognize significant changes before experienced clinicians. And this last sentence here is we believe. So we believe that we are having failures to activate METs. So right there, you're hearing what their gap is. We're not activating this as much as we can. And a mechanism for families to directly activate METs, there's their intervention. So they're saying what their intervention is. Could do a couple of things. Well, it could improve our collective recognition of changes of the child's status, increase activations, and most importantly, reduce preventable codes. So in one clear sentence, they actually nicely encapsulate their rationale for their work. Another example of a rationale is this one from an article. It's actually from 2011. I think the notation in the lower left is incorrect. But this is they were making changes in the electronic medical record. And so they pulled a diagram and a theoretical model from computer engineering about how you design the user, the task, and the technology. And they do a very nice job in this article using this as their theoretical framework. And all of their interventions, all of their data, all of their tables, and their conclusions all flow right from this diagram. This diagram's a little challenging. It actually takes you a little bit of time to understand it. But what I wanted to show you was that theory can be as simple as a clear sentence in a paper, or it might be a diagram of something you pulled from a different discipline or a different field. But we feel that rationale in theory is incredibly important to do better improvement work. Okay. Context. Hilary.
Okay. I'm going to stand up on the little platform here. I like this. Yeah, thank you. All right. So I'll talk just briefly about context in work. And when I think about writing about context, it really occurs from the very beginning. And I'll start here with the glossary definition from the Squier Guideline Glossary on what is context. And here they define it as physical and sociocultural makeup of the local environment. For example, external environmental factors, organizational dynamics, collaboration, resources, leadership, and the like. And the interpretation of these factors, sense-making, by the healthcare delivery professionals, patients, and caregivers that can affect the effectiveness and generalizability of interventions. So there's a lot there. It's almost more difficult to figure out, well, what comes out, what isn't context. So we have resources, places, people, beliefs, attitudes, sense-making, some very concrete, easy to identify things, and then some more conceptual things. And the other question that comes is that context can be dynamic during time and over the course of an intervention. So in talking about this the other day, we defined one way to think about context is that it is defined by the presence of an intervention, and that one almost has to have a sense of what actions one's going to focus on as attempting to change or to improve a problem in order to decide, well, what's there around it that could affect that intervention. And that the intervention almost needs to be there before we can clearly see what context is. And that actually, as we successfully change the environments in which we work, we often end up, if we're successful, changing the context of the future. So this idea that today's intervention is tomorrow's context. Where context occurs explicitly and both as a word and implied within the guideline items is in two different sort of scales. One is as an actual one of the 19 listed elements. Context itself under the method section where I often think about this as the setting. It's the space in which, the environment in which we're working that we describe locally. And if you're familiar with reading some of these articles, you'll often see one of the first spots under methods is the setting or the context of it. But most importantly, I think, and often very challenging to teach and to communicate, is where context then comes through in other elements of the methods and the results in the discussion. And so we see it here in setting, and then also that context comes up as we think about the measures that we use. So here, this idea that important contextual elements can be measured or tracked during the course of our work. For example, if we're working inside of a hospital and thinking about the length of stays of our patients, that something like a patient census, how busy people are, is a contextual element that will affect, how quickly you might be able to get someone through their hospital course and discharge from the hospital. And that will need to be tracking these other things in order to understand why an intervention may or may not be working. And that thinking about how we're going to measure those throughout our work rather than coming to the end of it and realizing, gosh, we had these things that may have affected our outcomes that we weren't measuring. Context is part then of measures with methods. It also is part of the results and how we report our results. So especially under C, it's mentioned contextual elements that interacted with the intervention. So similar to what I said, how things we may not have done work, perhaps in the space that we're targeting length of stay, but at the same time, perhaps in our emergency department, there was other work being done that may have either delayed patients getting up onto a hospital floor, or more work was done. So there can be even accompanying or parallel initiatives elsewhere that may have interacted with the work we're doing, and that can often be found in the results of papers as well. And this is similar, that the interventions that we may plan at the start of our work can be affected by contextual elements we run into, and we will report that we've modified interventions based on things we discover about context that we don't know until later. And then lastly, in the discussion sections, we see many places where context becomes an important part of understanding why an intervention worked or why it didn't work, and if and how an intervention might be applied to other settings. So it's reading through these, I think in the same way we can maybe understand intellectually what those descriptions might mean. When I've worked with groups, and when I've in my own projects wrapped my head around, well, how does this really work? I often start with this kind of a conceptual model. This is adapted from Kurt Lewin's force field model, where people think about their current state, a current problem, where we are now. And one place I do a lot of work is in around opioid use in the hospital. And so we may have identified a problem with excess opioid prescribing at discharge. So I could say, well, my current state is that I believe that we've prescribed too many opioids to too many patients for too long when they leave the hospital. And I would state that as my problem, and then describe the environment on which I work. We have 3 ward teams, we have this number of patients, this is what our patients are like, these are the way our providers are trained. So I would describe my local setting as part of that problem state. And then out there, I would have sort of a desired state of where I want to get to. So in the world that I would like to change into, we would have fewer patients being prescribed opioids. We would have them prescribed, the ones that were prescribed, they'd get fewer at discharge. So I have a present state that I can describe, and then sort of my outcomes that I'd like to get to. And then I can start thinking about, well, what is it out there that is keeping us in the state that we are? What sort of elements of my environment are preventing us from already being at that desired state? And those might be that I've got providers with some, what might seem like outdated attitudes about how much pain should be, or pain medication should be prescribed. We might have limitations in getting people back to see a provider in the community. So we worry, well, I got to make sure that they're covered until they can get their next appointment. So my time till follow-up may be a contextual element that's holding this in place. Or it may be order sets that default to a long day's number of prescribed medications. So I have a number of different reasons that I can think about and work with my group to say, why are we stuck where we're stuck? Likewise, so these would be the restraining forces. We also have these driving forces, which are things that are moving us towards there. So maybe I have strong leadership which says, hey, we want this changed. I've got a lot of media coverage just out in the community that might be changing patients' attitudes about prescribing. I might have a colleague who's working in the outpatient setting who is starting to teach a lot of our younger doctors that we need to change our prescribing patterns. So that might all be going on, and in the meantime I'm thinking, well, but I'm going to target one of these things, and I'm going to do an intervention which changes the order sets of, so that we default to a shorter number of days prescribed, and that, that will be my single intervention that I'm going to now study. And at that point then, having gone through that whole sort of what really is a thought process, a planning process early on, I've made explicit all these, this big cloud of the social elements, the structural elements that really pertain to my particular project and could explain, if my intervention is successful, how am I going to use that context to inform whether that intervention did succeed, based, where some other contextual elements may actually have been more powerful in pushing us to that state or in holding us back from that state. So that's really a whirlwind tour through this, but an example of the types of exercises we get started on in trying to sort of, I think, demystify what context can feel like, because it's it's like the air around us that we breathe that, we don't notice it until it's gone. And there's a challenge with that. So I think it's a very nice introduction then to this, what Louise will teach us about how studying the intervention, I think, departs from understanding of context.
So this is an impressive example of time management skills. It is 25 of the hour. And I have just a few minutes of content that I wanted to cover, but before I do that, because we can do it in a couple of different ways, could we actually stop for just a minute and we find out why you guys came here to hear us? Because then it will help me shape what I say to you, and it might help us make space for the right conversation. Do you guys mind speaking in public? Could you just tell us why you came? Because I think that would actually help me and help us. So do you mind starting?
Okay.
And do you all know each other? Okay, so maybe say your name.
Okay. I'm Virginia, and I'm from the Center for Statistics in Medicine, and basically I sit near Caroline, so I know quite a lot about reporting and improving the reporting, and I was interested about, I didn't know very much about Squier, so I was trying to see what was different from other guys, what did we know, and or approach anyway.
Okay, good. That's helpful.
Something where the same context one is Helena and also statistician at CSM. So again, we're thrown into full of guidelines. So
Okay.
I'm Sophie, I'm a diabetes dietitian, and I've been funded to do a master's in evidence-based healthcare at the moment.
Oh.
Part of the payback for the investment in that is the year after I finish, and I'm supposed to do some sort of healthcare improvement project.
Oh yeah, trouble, big trouble. Yeah. Good.
Yes, so this is very relevant.
Yeah.
I'm Gavin, I'm also a statistician at the CSM, and I suppose I'm just starting out in publishing and writing, so I want to get off on the right foot.
Yeah. And is your background is in statistics also? Great.
I'm Hilary Mosher, I'm a statistician. Just recently joined CSM for the last year, but prior to that I worked
for Houston Memphis Research Institute.
Oh, yeah.
And we
In
had
Texas.
Texas.
At MD Anderson, or near, no, next to, across the street from, yes, competitor too, yes.
Anyway, so I worked on helping them evaluate a quality improvement project we did on delirium.
Okay.
And, we actually submitted the paper to get it published, and it got trashed. So
Okay.
we can go back and say, let's see if we can model Squier this time.
Okay.
If that helps, but it's very hard to write these up because the intervention is usually multifaceted.
Exactly.
There's 10
Exactly.
components to them.
Yes.
And then also, it's kind of a new field.
Yes, that's yes.
And they don't have a real good handle on really defining what their outcome is.
Mm-hmm.
Right? So you don't really know what they're.
Mm-hmm.
And then whether they can measure it or not.
Right.
And it's just right now seems to be a big C. And I think that with the guidelines, they'll help with the design also.
Yes. Okay. So that's great. And yes, and actually we'd be happy to talk to you later about how to think about how do you tell the right story and how do you decide what story to tell, because no matter what kind of paper you're writing, whether it's quantitative, qualitative improvement, there's always a decision about what data to include and not include. They don't tell you that part in the quantitative world, but we also make decisions there, right? Like even when I do cancer epi work. So so I actually am gonna then this is why they had the block there.
Yes.
Don't move the block out of the way. So now I'm gonna be really tall. I just uncovered all the wires. So I'll give you sort of the brief overview of what we mean when we talk about studying the intervention and improvement work, and then we'll still have a couple minutes for questions, and then we can kind of discuss that. So, of the three pillars that underpin sort of the theory behind Squier and behind what we think the underlying ideas behind improvement work as a whole and how you do it and report it. The third is studying the intervention. This is the part that is really hardest for people in the improvement world. It's very meta. It took me several months to kind of wrap my head around it, and I continue to feel like I learn as I talk to people, and frankly, as the science of improvement continues to advance. All right, this is what we mean when we talk about studying an intervention. We're talking about an assessment of the impact of the intervention on the systems and people. Like, did it work, right? So at the most like beginner level is, did it work? It's like your primary outcome if you were writing a quantitative paper, right? Internal and external validity, like checking to make sure that your measures measure what you thought they were measuring. How about checking to see whether those measures would be applicable in other settings? Fidelity, did things get done the way you intended them to be done? Like, did you give people the checklist and then nobody actually used it, right? And maybe that's why it didn't work. Or did you give people the checklist and then you actually let people change it, like in that Keystone study in Michigan? This is the place where you report that. So Squier gives you an explicit place to tell that story of, we gave people the checklist, we said it had to be in these certain parameters, and then we asked them to modify it as appropriate for their settings. And so you give permission for that, you give a place for it, and you also show that maybe that's necessary in order to implement this in your setting. Whether or not the observed change was likely a result of your intervention. So did it work for the reasons you think it did? Because so if the delirium rates went down, is it because you changed the time you turn out the lights and you made the unit quieter? I'm just guessing it, maybe what some of the interventions were. Or is it because they stopped prescribing halcyon? We don't even use halcyon anymore, but they stopped prescribing drugs that were going to make people delirious. At the same time, because there was some conflicting policy change that actually changed the secular trends in your work and created this outside effect. Whether there were unintended consequences, both good and bad, right? And was the cost worth it? You know, opportunity cost is a real cost, monetary cost, and that's the one we usually think about. So Squier gives you this explicit place to explore those things. You know why we need to study interventions, right? So The Hawthorne effect. People change their behavior when you're watching. This is why sustainability of improvement work is such a challenge. Secular trends. So this is that idea that if you have some concurrent change in how we think about something in society, in culture, in our policy-making bodies, that's going to affect your improvement work. It may have a confounding effect. It may just be an effect modifier. There might have been a cultural shift, which kind of would change actually overall how people think about things, and that affects your intervention and how it's taken up. There might have been some external pressure in the US. You know, it's always like about market forces. I don't know what they are here exactly, but I get the sense that the NHS, when they set policy, that's sort of the equivalent of market forces in the US. Changes in procedures at a facility are going to change what happens with any intervention that you're doing. So this is why we have to study it. Generalizable lessons down here at the bottom is one of the key reasons why you write up improvement work, and is one of the real things that you want to get at. If you study an intervention well, chances are you'll come up with the generalizable lessons that might result from that work that might be applicable to something that actually is in a different specialty or different problem area, but raises some of the same issues when you're trying to implement something in a new place. So we think about studying intervention in a couple of ways. So you can use a specific study design, right? So this would be the part that is probably easiest to understand, right? You can use a randomized trial. You can do a cluster trial of different ways of implementing things in different settings. That gives you a way to make comparisons. Which way works better, right? A stepped wedge, which is a rollout across sites. Quasi-experimental designs can also be useful, right? They all have their limitations and their advantages and disadvantages, and you might choose a different study design depending on what it is that you're trying to do. This is very common in improvement work. We don't know how to randomize. Like, it's free, we're doing this on our spare time, so it's single-armed. There are still ways to check what's going on with your intervention, right? So you can take advantage of techniques from the field of evaluation. So this is where you start to draw in other approaches that go outside of what we traditionally think of first in medicine. Process evaluations. How did the change occur? What were the unanticipated effects, right? This is part of it. How did this program affect the people who were participating? Was the cost worth it? There are actually a lot of ways that you can do this just to understand what's happening when you implement it. And even if the Keystone trial, the Michigan trial that Greg was describing at the beginning, had not been a trial that they did across sites, they still could have used these techniques to tell us more about it and tell us whether it had been successful and why. Was it really just the checklist, or was it these other things? So just to get at this a little bit more, so reporting outcomes is different than studying the intervention. Studying the intervention at a minimum is about understanding why or how the things got better and whether things got better because of your intervention, right? So you're like trying to think about like what are the different approaches we can use to test that. So if you try this out mentally in a little thought exercise, let's say you use a two-pronged approach to increasing hand washing rates in your unit. In one place, you provide departmental rates on a public dashboard. This is a very popular approach, right? Where you like put up the number 87%, like that's this week's hand washing rate in this unit. And then in another part of the hospital, I've seen this used in pediatrics units, you post a picture of this beautiful child like playing on the beach before they got sick and were in the hospital. And then you post a hand lettered sign that some family member made that says, please wash your hands before you come in my child's room. And so then you test like which one of these things works better. So you report that hand washing rates got better over time in your study, right? So you report your outcomes. They got better actually in both units a little bit. How might you actually study this intervention if you found that the displaying pictures of the children when they were well worked better than public dashboards? Here's one way you might do it. You might actually ask people, did you look at the public data board? Can you tell me what the hand washing rate was for your unit this week? Like, so you could just check, like, are people actually looking at it or are they not? You could ask people their opinion about whether they thought the family member thing is better than the dashboard or whether they notice the difference. So there's those simple ways to do that that are different or perhaps would augment the comparison that you get by saying what happened in this unit versus this unit. If the differences weren't that big, you might say, gosh, is it because actually everybody works in both units? And so there was so much crosstalk that actually the whole thing just affects them the same way. We always say it's actually pretty helpful to, in order to figure out what to do to study an intervention, you want to go and look back at what your rationale or theory was, because that'll usually tell you a lot about what you should be checking to make sure it worked. Ideally, and you're now in the uncomfortable position of having to go back in time and try to figure this stuff out, but ideally you want to develop the study of your intervention into the design of your work from the start. And this is why we actually encourage people now to use these guidelines before they start their work, not at the end. We always say it's always good to be a little skeptical of your success. You know, people who work in the improvement world always want things to get better, and sometimes our interventions make things worse. And so, if they really got a lot better, like, just, you know, be cautious. Like, is it because of what we did? So here, this might be helpful to you. So we do encourage people now to use our guidelines in advance, which is a little bit of heresy around publication guidelines. Traditionally, the advice has always been this is really about writing, it's not about designing. But based on what we learned in our evaluation process and the road testing, we feel strongly now that it's okay and encouraged to tell people that it's okay to use guidelines in the beginning. Be clear about why we thought we should do this now. Try to make sure your measurements will help you in advance answer the questions that your reviewers are going to have about why this probably actually is not the reason it worked, or why we actually probably shouldn't care about this outcome. And be writing all the way through the work. So we didn't touch on this much, but the way to understand context and the way to know that you're studying the intervention is actually to be keeping really good records. So records about what changes occur during rollout and implementation are sometimes get lost in the shuffle, and so keeping track of those can be an important part of the work. So Squier lives here. Of course, you know, you're part of Equator, so you just go to Equator, but we have our own website where the guidelines do live. And these are the journals that co-published with us. So as you think about where to publish your work, both of you who are going to need to do this work, these are places that the editors said, we're so interested that we actually want to put these guidelines in front of our readers and in front of the people who are in this specialty. So that may be helpful to you. These are the people who are on our steering committee for the development of Squier 2.0. I think Greg and I feel basically like we're almost more like the conveners, frankly. We are not the people who are like the thought leaders, but we are the conveners, and a lot of really great people have led this work. So maybe I'll stop there, and then if there are questions that we can answer, or anything, or if there's anything you want to talk about, we would be happy to help. And we're curious to hear what your reactions are actually to having heard this, and how does this strike you?
Really useful to me.
Yeah.
I've been struggling with getting my head around how I can do something useful and measurable without getting into RCTs and that sort of thing. So it gives me some ideas how I might approach.
Yeah. Yeah. And for those of you who are the statisticians, like, what do you think of this?
The journals that you put is, when you say you co-publish with them, does it mean that when someone wants to publish in that journal, they are requested to look at this file? Or?
Oh, that's a great question.
Yeah.
So most journals have very few, if any, guidelines that they will require people to use, and it's very specialty specific. So like, I think I'm in the field of otolaryngology, so ear, nose, and throat stuff. And our journals generally don't require that you use any publication guidelines. I don't know why, but they've sort of made an editorial decision that they're not going to require them. But if you go to BMJ, like, you cannot publish a paper in there without like filling out all the checklists. So it's very journal specific. So just because they co-published doesn't mean that they're going to require that you use it or that they're going to make you fill out a form. And yeah.
I thought, just sort of be helpful. I'm mainly involved in surgical trials, which this is very relevant, I feel.
Yes.
They're obviously very complex, and it isn't like there are a lot of external factors. But yeah, I find myself that, well, anyway, they don't tend to, in my opinion, sometimes it's the word count, but you don't have the chance to explain your intervention quite a lot. That's
right, exactly. And so I know as we have really struggled with this, we actually talked about, like, should we move from the IMRAD method of reporting for these? And we decided that no, we thought that wasn't the right way to go. But I do think we are hoping that this will spur the conversation to use electronic files to post, what were your interventions and the iterations of your interventions, so that we have ways to share that. I think we haven't thought about it much in the trial world because it didn't occur to them, but clinical trials are incredibly complex to put together and put on. One of my colleagues is doing a colorectal cancer screening trial across 40 different sites, and the mechanics of how you ran it might be useful to tell other people about. There's no place for them to report that, but if you put it in your guidelines and then said, please make available electronic space, maybe that will come in the future. Yeah. Greg, your thoughts?
Actually, what you just about the electronic and the supplemental material, I think is part of it. The other thing you had asked the initial question about the journals. Interestingly, some journals that didn't want to co-publish Squier, but they actually, I think of the Journal of Pediatrics, they have a section of the journal every month that is quality improvement reports, and Squier actually is requested or required for that. Oh.
So they didn't co-publish, but they want to require. So that's interesting.
So
I forgot about that.
What we tried to do is really reach out to a lot of different journals. And so some of them are sort of the quality improvement journals, like BMJ Quality and Safety and the Joint Commission Journal on Quality and Safety, and some of them were specialty specific. So we tried to reach out to both to try to say, hey, this is a tool. Are you interested? And if you find it useful, please use it. And that was helpful.
Yeah. Yeah. Other reactions or thoughts to this? Yeah.
You mentioned about how important it is to report if things don't work.
Yeah.
Do you think there's a problem with when you're trying to get that published? Do you think there's a kind of publication bias? Do you think that's?
Yeah. Can I?
Yes, please do. Yes. Yeah.
We did this workshop up in Leicester, and yesterday afternoon we were working one-on-one with a bunch of teams. That's the kind of the writing, and one of the groups was actually had been working in care homes, trying to increase residents' water intake, liquid intake. So it's about 1,500 cc's a day is what's recommended, and they made so many changes over 14 months, and not a damn thing happened. It just stayed the same. It's really. It's like, it should be simple, right? It's
get them to drink more water.
Get them to drink more water. And there's so many reasons why it didn't happen. And in some way, what we sort of discovered was if they had a positive trial and things got better and everyone was at 2 liters a day, it'd be easy to write. And so there was actually making it harder to write because they made 7 or 8 different changes and they're not quite sure. And they think some of them worked a little bit, but they didn't sustain, and other ones didn't work at all. So it's actually, now they have a whole bunch of data because they had observers who were making field notes, and so they actually they're going to wade through that. So it's a really good question. I think it's actually harder to write it because you don't have this clear story about we wanted to do this, we planned it, here's what we did, and look, it got better. We wanted to do this, we planned, we did all this, and nothing got better. It's almost harder to explain.
Well, it is, and there's so many reasons for failure.
Right.
And writing, I recently had to write a negative outcome paper, like where I couldn't do what I had been funded to do, but I felt like it was important to communicate that. It took me like a year and a half to write that paper. It was complete torture. It's so hard to report negative results because we don't have a great framework in medicine for how you report a failure. Dude, it's very interesting. So yeah, there's publication bias, but I also think it's like so hard for authors because we don't have that framework.
We don't have a framework,
Yeah.
But I think with this idea of study of the intervention, there's starting to be more realization that even a positive study where the outcomes improve, they drink more water. If the intervention hasn't been studied in a way that one can connect present state to the improved state, it's an equally useless study in many ways. It just isn't obviously necessarily useless because it appears there was a change. But I think that what I was taught very early on is never get into doing something where the value of it depends on the results that we get, right? I mean, because you want to say, well, so if we do improve this, what have we learned? If we don't improve it, if our study is negative, what can we report that we learned? And if you ask yourself those questions, then I think you're pushed, to set things up and to study the intervention, to record these measures, so that you can then explain, despite this huge investment of effort, we didn't see a change, and we think it's because there's this other thing we didn't know about, we didn't consider that should be the target of our next work. So
I think that sort of thing is more valuable than stuff that works, because it might work, but it might not work very well.
Right. And I mean, we have the same issue in randomized trials, right? We try to control for those things that we think will negatively impact by by selecting those people out. And so you're almost doing this like study of the intervention before you even do it in a randomized trial, making sure your design sort of will account for these things that would tend to make your outcomes not useful, or that will tend to make you not have either a approval or disapproval of the null hypothesis because you failed to notice that there's this confounder in there. So it's actually hard stop at 2. So we're still here, but you probably need to get back to work. But if you have questions or want to ask us, please feel free to stay. Thanks so much for coming. I'm glad we got a chance to talk with you guys. We're just here. We just happen to be here, so we feel lucky to show up. We get to see you.
Thank you so much.
Yeah.
It's really interesting. And is it all recorded for posterity? So we're hoping to make a podcast of this. So